Night, everyone. Welcome again to one of my webinars. Today, we're going to talk about endometrial cancer. I want to thank brightbud.com for sponsoring this webinars. I want to remind everyone that your microphones are going to be muted throughout the presentation, but at the end, we're going to give some time for you to ask questions, which is my favorite part. Also, I would like to remember that this is based on my medical experience and does not replace medical consultation. Also, I encourage everyone here, if they have further questions at the end of the presentation, to go into brightbud.com and record those video questions, and somebody, either me or someone else who knows about it, it's going to answer your question. So let's begin. As I was saying, today we're going to talk about endometrial cancer. I decided to title this presentation A Cruel Irony, and I'm going to explain later why. For those who are new, I'm Jaime, Dr. Jaime Meza. I'm a medical doctor experienced in emergency medicine and chronic diseases. How important is endometrial cancer, and why are we talking about it? Well, at least in the United States, it's very important. This is basically very similar to the numbers around the world, but just to talk about the United States, it's about almost 4% of all cancers. It's the fourth most common cancer in women, and it's actually the most common type of uterine cancer. About 60,000 women die every year from it, so it's a lot of women. It's very, very, very important, and a little bit more than 10 times that are the women who actually have to live with endometrial cancer every year. So it is something that is very important, and we can address it, especially because the 5-year survival rate, it's 95%. What does it mean that 95% of women diagnosed with endometrial cancer in early stage are going to live at least for 5 years more? And obviously, the earlier they caught it, the longer they're going to live. So this is actually good news. But of course, the key word here is early. As in almost any other cancer, that's what makes the survival rate change time. So this is something you should be aware. I'm not really sure why so many people talk about breast and cervical cancer and not so many people talk about endometrial cancer. So I would like to add it here. The pink ribbon is for the breast cancer, but the orange, like the peach ribbon, is for the rest of uterine cancers, including endometrial. But what is endometrial cancer? Well, like I said, it's the most common cancer of the uterus. It affects the lining of the uterus, which is the inner part of the uterus. And of course, as other cancers, it's an abnormal multiplication of cells. In this case, well, the endometrium cells. Here I have a picture which shows the normal reproductive system of a female, and you can see here the different layers, including what we're talking about now, this part that it's called the endometrium. I'm gonna explain that a little bit more. So now, what is the endometrium? And I think this is the important part to actually understand. And I try not to be very scientific about it, but of course, I have to name certain things, but I'm going to try to explain it the best I can. So first, The endometrium is the inner layer of the uterus. Here in this picture, you see, you're gonna see it as a dark red, in contrast to the light pink, which is around. This is the endometrium. Here in this image, you will find how that endometrium changes with the menstrual cycle. So basically, the endometrium is a tissue that's made of glandular tissue, and it's highly vascular, which means that it's highly responsive to hormones. This is the main characteristic of this tissue. Of course, women have changes throughout their menstrual cycle in the hormone production, which makes this tissue react according. So it is divided in two layers, one that is called the functional layer and the other one that's called the basal layer. Basically, the one that we're going to talk about is the functional layer. The basal layer, it's basically the one that attaches the endometrium to the muscle, which is here represented like in pink. This is muscle. The uterus is mostly muscle. So what attaches the endometrium to that wall, to that muscle, it's the basal layer. The functional layer is the one that has all the glands and all the blood vessels in it, and it's the one that is reactive to and responsive to hormones. Basically, the purpose of the endometrium is to prepare itself for the implantation of the blastocyst, which is the embryo. Basically, that's the function of the endometrium. There's no other or function for it. Basically, it prepares throughout the whole cycle, the menstrual cycle, to a pregnancy. And of course, if that does not happen, then it sheds away and the menstruation takes place. So basically here, I try to explain that. Of course, what I'm trying to show with this picture is how thick it becomes before the menstruation, and then it goes, you lose that tissue and that blood, and then it starts all over again. So we're talking about cancer right there in that very, very, very thin portion of the uterus, which by mostly hormonal causes, it starts to overdevelop. What are the symptoms of this cancer? Basically, they are related with two main things. One, it's bleeding. It can show itself as spotting, which is some bleeding between periods. And mainly, the main symptom, it's bleeding after the menopause. It can appear like if women were having their periods again, or simply as pinkish or reddish vaginal discharge. So this is very, very important for women to remember. After menopause, once you stop having menstrual cycles, you shouldn't bleed again. This is a symptom that something might be wrong and you should be checked, especially if this comes with pelvic pain during or after intercourse. Of course, these symptoms can happen one by one or together. Of course, bleeding, it's a little bit more related to that, but all of this can happen. Maybe only pain, no bleeding, but that's also a symptom. So you have to be careful for all of the symptoms. What are the risk factors? For this slide, it's very similar to the one I used for breast cancer, and it has obviously a reason. So you'll see that age is definitely a reason. It happens more in women in the postmenopausal age after their menopause. So of course, age has to be related. Again, the same as breast cancer. The sooner you get your period and the more years you have it, so the later you get your menopause, that's going to be a risk factor. The endometrium responds to both estrogens and progesterone, which are hormones that are produced by the body, and especially in female bodies, in a cyclic way. Of course, that controls the menstrual cycle. So of course, this is what affects, and this is the relationship between breast cancer and endometrial cancer. That the non, again, which tries to tell us about not having children. Women who never had or never got pregnant, they're at higher risk of developing this type of cancer. Obesity, because going back to other webinars, and if you were not here, obesity, having a lot of body fat, makes or creates certain misbalances in the hormonal production, because cholesterol is the prime molecule to create both estrogens mainly, but can also create other types of hormones. Having polycystic ovarian syndrome, and we talked about that before, but of course, being the main factor in that condition, the hormonal misbalance, then of course it is a risk factor for here. And receiving hormonal replacement, especially estrogen replacement therapy, it's a risk factor. And that's why it's there's a little bit of controversy about using it. Of course, there are certain patients that need it, but they need to be closely checked by somebody. Unfortunately, menopause, which is something we're going to talk about in another webinar, but unfortunately it causes a lot of symptoms which are very unpleasant to certain women, and they go to their doctors asking for replacement of their estrogen to get rid of those unpleasant symptoms. And unfortunately, some of those patients are not checked well enough, and they might end up developing endometrial cancer. So of course, each patient for that therapy has to be selected very carefully. How do we diagnose endometrial cancer? Of course, in medicine, everything follows a certain path which is similar, and of course, we have to suspect that you have it. So before any other test is done, just a visit to a gynecologist or even a family practitioner and a regular physical exam will reveal that you might have certain signs of the condition. But after we suspect you might have it, the first thing we would like to do is an ultrasound. An ultrasound can be made in different ways, mainly transabdominal, which means it's done by the abdomen, like under the belly button, or in this case, transvaginal. And there's a lot of difference between those two ultrasounds. And it's not a very pleasant exam, of course. I wouldn't say it's necessarily painful, it's just unpleasant, but it's very necessary because it takes the transducer, which is that this device here, closer to the uterus, so the image we get, it's actually more accurate. Here I have a picture of an actual ultrasound, just to let you know a little bit of what are we looking for. Of course, this has to go with a little of imagination, but you have to trust me that this is the uterus. It's like an image, like if you take a lemon and you cut it in half. Basically, that's what we're seeing here, 1/2. So here we have the line, and here in a well, everything is gray, but here this is a lighter gray. You see the endometrium, the lining. So of course, what we do is we measure, and we know a certain standard. Of course, as I was saying, this changes throughout the cycle. So in women that are not in their menopause, it is very difficult for us to know what's abnormal because that's always changing. But in postmenopausal women, it's easier for us because we know it shouldn't be thicker than a certain number. So basically, this is what we look. And if you see this image, you'll notice that it is kind of hard to actually see and to identify anything there. So imagine if we do it from farther, from here, from the abdomen, the image is not going to be clear enough to make a good diagnosis. So that's why we use it. This is the first step. The second step, it's the endometrial biopsy. Cancer is a diagnosis that needs to be confirmed always with pathology and histology, which is basically taking a sample and looking at it through a microscope. This is a procedure which I see, and a lot of, 2 or 3 times a week. And I've noticed that women are very afraid of this procedure. And I'm here to tell you that it's not as bad as you think it is. It's basically a procedure that it's done in a procedure room, doesn't need anesthesia, doesn't need sedation, just the patient to be relaxed. It is used with a regular speculum, and what they are doing is that they're gonna introduce through the cervix and through the os, which is the little hole in the cervix, something to just take a little sample of the tissue inside. This is another view of basically when that goes in and just takes a little sample. It feels, of course, I'll never know how exactly it feels, but what patients tell is it feels like menstrual cramps. That's how it feels. Probably bad menstrual cramps, but it takes the whole procedure probably 15 minutes, so it's not that long. And in the other hand, it's a procedure that will give us very valuable information. So if they find something in the ultrasound, they will proceed and do the biopsy. How do we treat it? Well, the first treatment and the most common one is surgery. Hysterectomy is the treatment we use the most because it's very, very risky trying to get rid of the cancer and then controlling it every year or every 6 months. It takes a lot of effort for actually knowing that this that the other treatments worked, and you have to put in a balance the risk and the benefits of that treatment. As I was saying, the women that are affected the most by this cancer are postmenopausal women. So that means they're not going to be able to have children anymore. So they're not going to need that their uterus for that purpose anymore. So it's based on the risk of having it, of leaving the uterus in. I think it's the safest thing to do, just get rid of the whole organ. Of course, it depends on what stage the cancer is diagnosed. It can be a regular hysterectomy. It can be a total hysterectomy, which means the cervix is taken also. Of course, that's what normally they do for this type of cancer. And actually, they do salpingo-oophorectomy, which means they take the tubes and the ovaries also, because they don't want to, once you get the surgery, we like to make sure that you don't have, and you're not going to have any more problems with that. So just one surgery, because the risk of having to go back and do another surgery, nobody wants to do that. So that's the most common. Of course, radiotherapy, it's another one that we use a lot. It can be done in different ways. There is actually a local radiotherapy, which is called brachytherapy. That's used for cervical cancer. That's also used for endometrial cancer. In men, it's used for prostate cancer, which basically consists in introducing radioactive material closer to the tumor, wherever it's located, via, in this case, the vaginal region, and it's attached to the cervix, so the radiation it's there for a continuous period of time, and that can also work. And regular radiotherapy, which means you go and they put a machine that's outside of your body, that can also be done. Usually they do it once the cancer is a little bit more advanced and they just want to combine the hysterectomy with something more, just to make sure they got rid of the cancer. Of course, they can also use medications to block the estrogen in your body. As I was telling you, the estrogen basically is the hormone that makes this tumor grows. And it's not only the estrogen, actually it's the misbalance between estrogen and progesterone. And this is very, very important because some women ask if this is caused by estrogens, why the oral contraceptives do not cause this cancer? And of course, it's because most birth control pills have both estrogen and progesterone together. So it's not actually the level, but the balance between these two different hormones. So they can use also medication to block estrogens. Regular chemotherapy, it's very, very used once the cancer is a little bit more advanced, probably metastasized. And progesterone, of course, that helps the balance of these two hormones. Okay, so here's the part where I hear your questions. I thank you for your attention. You know, I love this part, so let's hear those questions.
Dr. Mesa, once you take out everything, the uterus, the cervix, the tubes, does a woman still have any sexual feelings?
Yes. I guess it depends. There are certain factors that need to be taken. The sensation, it's not going to change. Fortunately, the nerves that bring the sensation to the vaginal region are not usually severed during the procedure. There are certain things that might change, that might actually change the whole sexual experience. If this happens to a younger woman, of course, certain things might change, because you have to realize that once your ovaries are gone, then you're going to start menopause. On the other hand, if this procedure is done in a woman that's already in her menopause, then that's not going to change a lot. So what can be experienced? Basically, dryness can be, it doesn't happen to all of women, but they can be more dry, so they might need some lubricant for that. But the feeling doesn't necessarily change that much.
Would it be more painful, Dr. Mesa? Would this, for sexual relationships, would it be?
It depends. It can actually be less painful, because one of the symptoms, it's actually to have sexual pain during the intercourse. So if that's the case, probably the surgery will help. Of course, we have to know that the anatomy in that region, it's a little bit more complex than what I can show right now. And of course, when you lose your uterus and you lose your ovaries, there are some ligaments that are cut that they help having certain stability and the shape of the vaginal area. But if the surgery is done correctly, and of course, I'm not talking about the skill of the surgeon, but more of the specific case of the patient, because not every patient is the same. But if everything goes according to plan, there's not going to be much change. So probably it's not gonna be more painful. Of course, I'm pretty sure if we read some literature about it, there might be women who actually might experience more pain, but I don't think that's like the typical case.
Okay.
Dr. Mesa, is uterine cancer and endometrial cancer one of the same?
Endometrial cancer, it's a type of uterine cancer, but they're not the same. They are sometimes confused, and people use the term indistinctively, but they are different. I mean, I can say, for example, that cervical cancer, it's also uterine cancer. So that's the big category here. It's uterine cancer, and it divides into stromal cancers, endometrial cancer, cervical cancer, and some other cancers. But of course, this is the most common out of all. Endometrial cancer is the more common.
Okay. And you did mention, I'm looking to see if it's actually curable, because you mentioned, and I'm not sure if I got it correctly, a brachytherapy.
Brachytherapy.
Spell that for me.
B-R-A-C-H-Y. Brachy.
Oh, brachytherapy. Okay.
Yes. This is the best part of all, is that this type of cancer is very, very curable. It's one of the cancers with the most successful rates if it's caught on time. And fortunately, and I think that's why maybe nobody or not that many people talk about it, is because we are improving a lot. So it's not, people think it's not that dangerous anymore, because we have a very good rate of success with the treatments. It is very curable if it's caught on time. So if you have any symptom, just go, and the biopsy is not as bad as people say it is. It's a very normal procedure. You're going to be able to walk that day and work that day after the procedure. So I think there's going to be one time in which hopefully the rates are going to be 100% of women with cancer are going to be cured. And this is the first one that's going to be cured 100%, because the treatments are easy, especially hysterectomy for early stages. It's very, very successful. So it's very, very easy. Well, it's not very, very easy, but it's easy with the right treatment.
So then you would think then that the survival rate would probably be in the 90 percentile, or not that high?
Well, it depends. We try to give periods like 5-year survival rate. Like I was telling you, right now in the United States, it's the survival rate for the next 5 years after the diagnosis, it's more than 95%. It's closer to 95 actually. A 10-year survival rate, that's a little bit less, closer to 68, 70%. But of course, there are many, many variables that play in this. Race, for example, unfortunately, each race behaves very differently with the symptoms. In this case, Black population and Black women are being diagnosed later, so they are dying more, because once the diagnosis is made, it's a little bit too late. So of course, we're trying to figure out what symptoms are more common in each population, to know when to act. So I would recommend to be even more careful. Of course, Hispanics, we have certain burden with certain other conditions, but in this case, the Black population are the one that's dying the most. So that the survival rate for Black population, it's different. It's not 95, probably it's closer to 85. It's not that different, but it is different. And of course, we would like to change that, but it's only because of physiological conditions that are determined by the genes.
Dr. Mesa, is all endometriosis cancerous?
Sorry, can you repeat the question?
Is all endometriosis cancerous?
Okay. Endometriosis, which is another topic we're going to talk about, so I'm glad you asked. It's a different condition. Basically, just to have like a quick answer, endometriosis, it's when endometrial tissue, it's located somewhere else in the body. So this tissue, instead of being just in the lining of the uterus, it's located somewhere else. Usually it's in the abdomen, but it can happen, I mean, there are rare cases which there's this tissue present in different far away locations from the uterus. So it basically bleeds with the normal menstruation, and that causes a lot of symptoms. So it's not necessarily related to this. There's another condition which is called hyperplasia. That is related with this because hyperplasia is the abnormal growth of that tissue. So if there's hyperplasia, that means the hormones are acting on that tissue, and if they act for so much, I mean for a long time, it might cause. So hyperplasia, it's related. Endometriosis, not very related, or not necessarily related.
Okay, thank you.
You're welcome.
Dr. Mesa,
yes.
You mentioned hormone replacement therapy as high risk that could contribute to endometrial cancer. What about women that have gone through in vitro fertilization treatments?
Yes, well, definitely part of the fertilization, and this is not exactly my expertise, but part of the in vitro fertilization comes with certain hormonal therapy to guarantee that this is gonna have the best chance. So I think it might be at a higher risk. Of course, there's very few population that might have it, so probably that's why it's not considered like a common risk factor. But I would say yes, everything that has that creates a misbalance between estrogens and progesterone might potentially be a risk factor.
Okay. Thank you.
What about fibroids? How do they affect the uterus and cancer?
Fibroids are located usually in a different part of the uterus. In the image I had, I explained that there's like most part of this organ, it's made of muscle, and the fibroids are present in that tissue, which is called the myometrium. What they cause, it's the most common symptom, it's abnormal bleeding, which is also another webinar that I'm going to do. Why? Because it distorts a little bit the shape of the inner part of the uterus. So it doesn't let the rest of the organ behave the same way. It creates like obstruction, and therefore the bleeding in the menstrual part of the cycle, menstruation, it's longer, but not necessarily a risk factor. Polyps, which are a little bit different from fibroids, might be related to some cancers, but usually in very specific cases of people who have certain conditions like intestinal polyposis or familiar intestinal polyposis, which is genetic condition that creates certain malignant polyps, but usually fibroids are not very related with this. I'm going to talk about that in other webinars so you can be sure that you're going to have a better explanation, but basically they're not.
Thank you.
Para nada, es que lo muestro humano.
So Dr. Mesa.
Todo lo contrario, o sea, la gente lo...
Yes, yes.
Oh, okay. I thought someone else was asking a question. So endometrial cancer is confined to the area of the uterus. If you have a hysterectomy, is there any chance of you getting the cancer somewhere else in your body or just in the uterus area? That's it.
There's cancer as a general rule or in general has the ability to locate in different parts of the body, which is metastasized, basically. And this can happen. The good part about it is that endometrial cancer tends to spread very locally. For example, to the urinary bladder or to the rectal region, but it's confined to the pelvic region first. Of course, once it's very advanced, it might start actually spread farther away. But if this is diagnosed on time and we know with tests that the local lymph nodes are not affected and there is no evidence of the cancer spreading anywhere else, hysterectomy, it's going to be almost 100% effective. Of course, this will never be 100% because there are certain cases in which the cancer has already spread, which we're not going to be able to detect until later. But this is a very, very low percentage of patients.
Okay. I have another question. So if a woman gets pregnant and she didn't know that she had the endometrial cancer, what would you suggest that she does? Or what's the normal procedure?
Wow, well, that's a very, very difficult question. Very interesting question, of course, but very difficult because as doctors, we're trying to save lives, but the question is, which life are we going to save? The baby's life or the mother's life? We are, or at least how I was taught, is to save the mother's life because she's going to be, if the treatment, she's already, by saving her, probably we will guarantee the best result because probably she's not going to be able to get pregnant later on, but she'll be able to produce more for the society. If we let the cancer basically advance, probably that pregnancy is not going to continue to a full term. For cervical cancer, this is more common. The odds of actually taking that pregnancy to a full term are greater, but for endometrial cancer, that's not very common. It's almost incompatible to do. So in both cases, I would try to save mother, but of course that's not a very easy decision, and of course we have to respect whatever the patient wishes.
Thank you.
You're welcome.
I have a quick question, Dr. Mesa.
Yes.
A pap smear, would that detect endometrial cancer?
That is a great question. Actually, I think one of the best questions, and the answer is no. That is a misconception that many patients have. But pap smears are designed, and they were created to detect cervical cancer. It's actually a very, very local procedure in which we basically with a brush take some cells from the cervix. As I explained in that webinar, the cervical cancer develops in the most outer layer. So if we take cells from there, we're going to be able to detect it. The endometrium, it's in a very different location inside of the uterus. So for cells to actually go there from that part to the cervix, it's hard. Of course, every time this abnormal bleeding occurs, some cells are gonna go there. But usually, if we even get some cells from there, the pathologist, it's not looking for that. He's just looking in his microscope for cervical cells, and basically he will ignore, in most cases, this type of abnormal cells. So it's not a very good, actually it's not a test for that. I wouldn't recommend it. It's totally different.
Well, thank you.
You're welcome.
Sir, I don't know if you said this, but I got the feeling that this type of cancer has a higher occurrence in postmenopausal women. Is that the right impression?
Correct. Totally right.
Okay. Another question though, in premenopausal women, in terms of the original diagnosis with the imaging, is there any benefit to maybe having someone do the imaging, say, at the beginning of their cycle so you get a better reading, or is that even matter?
It matters. It matters, actually. As I was telling you, doing ultrasound in premenopausal women, it's always a challenge because the measurements are going to be changing all the time. Of course, if we take that readings in the moment where the hormones are at its lowest levels, that might be a more accurate reading and might tell us more. So yes, I definitely would change things. It will still be difficult to interpret the results, but if I was going to choose a date to do it, I would definitely try to do it when the endometrium is at its thinnest point, which is after the menstruation. So that definitely changes.
Okay, thank you.
You're welcome.
Dr. Meza, I have a question.
Yes, go ahead.
Thank you. I have a very young daughter, and sorry. Thanks. And I would like to know your professional opinion towards the vaccine, that very famous vaccine that people are talking about. If it really helps, she comes from a family who has, cancer history. And I don't know, I would like to know your recommendation. What would you think about that?
When you're talking about the famous vaccine, I guess you're talking about the HPV vaccine for the human papillomavirus. Yeah. Well, there's a lot of controversy about it because there has been some reported cases of some adverse reactions throughout the world. But those reactions have never been reproduced in lab settings or in control settings. So basically, the World Health Organization and every respectful health organization in the world, it's still recommending the vaccination of women, and it can be used also in men. So in my professional opinion, I would definitely do it. Of course, there's a time in which you're supposed to do it, but for your daughter, I would definitely do it. This is game changer. It changes the odds, and risk benefit, definitely the benefit, it's totally better.
Thank you very much. I appreciate your answer.
You're welcome.
Hi, Dr. Mesa. Is it more likely, to the extent that that the cancer metastasizes, is it more likely that that endometrial cancer will metastasize to just garden variety uterine cancer? And I ask that because I know you said that it stays local, but it would also seem that cancer can go in any direction it wants, and it does, so if it should metastasize, is it typical for it to metastasize just to uterine cancer, or is it more typical to be to spread to the ovaries, for instance, or some other place?
Well, like I was saying, the typical is just to be very local. But when we study cancer, we know that there are several types of mechanisms for tumors to spread. Some tumors do it by the bloodstream. Some others do it by the lymphatic way, which is another type of mechanism. So that makes or tell us how easy it is for the cancers to go to places which are remote, let's say from the uterus to the brain or to the bones of your arms. So fortunately, in this case of endometrial cancer, the most common thing is just to stay local, then grow into the uterus and actually even take the cervical region, not a cervical cancer, but just grow enough, and then it starts growing and affecting the bladder and the rectum, and then we might start seeing it go to other places. That's basically how it works. Of course, there are exceptions to this, and maybe there are cases in which no other symptom and just a very local tumor was present, and then they had metastasis in another remote place. But the usual thing is just very local at the beginning.
And another question: if a young woman who hasn't hit menopause yet takes other drugs that play with her hormone levels, and so, I mean, is that enough to trigger? Is that enough for her to begin to be worried about maybe triggering endometrial cancer?
It might. Of course, what I'm telling you is that the progesterone and estrogens need to be in a certain balance. If whatever drug that patient's taking causes a rise in both equally, it's not going to be a problem. For example, birth control. Nowadays, we have two different pills, ones that only have estrogens and the ones that have both estrogens and progesterone-like hormones. Those are safer because the ones that have only estrogen will cause a misbalance, so that will trigger will increase the risk. If we're talking about other medication different from birth control, other hormones, well, we have to analyze that case very specific, because certain hormones, thyroid hormone, for example, might affect that balance. So it might be also a risk factor. So hormones are all linked together in a very complex mechanism. So affecting one usually affects the other. So probably it is going to be a risk factor.
And would you say that the hormone concern is a more important concern than a woman's chronology or her age? So, you know, it can affect both older women and younger women, but you said it's more likely to affect women after menopause, but it can affect younger women. So is the age of a woman as important as the hormones, or is it less important? Well,
they're actually related, because what's important actually is the misbalance of the hormones throughout years. So that's why postmenopausal women are more at a higher risk and not younger women, because that misbalance starts happening when they're adolescent or adult, and then having that misbalance for years will eventually produce the cancer. For example, the case you were telling me, taking hormones. If you're taking hormones probably at 18, when you're 25, nothing's going to happen. When you're 30, nothing's going to happen. But then at 40, or once you get to the menopause, those are the women that are going to develop. So age is as important as hormones because they are linked together.
Thank you.
Okay. Thank you, everyone, for your attention and for your questions. I enjoyed them. Hopefully, you can join me in my next webinar. And please remember, if you have any other questions, just go into brightbud.com and record them, and I'll be happy to answer, or another doctor will do it. So thank you very much. Have a good night.